Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining me today for this educational module, Sifting Through the Data, what you need to know to share the metastatic urothelial carcinoma decision-making with your physician. The educational process is supported by an educational grant from Pfizer Incorporated and EMD Serramo Incorporated. I'm Dr. Daniel Petrolak, Professor of Medicine and Urology at the Yale School of Medicine. I'm co-director of the Signal Transduction Research Program in the Smilow Cancer Center at Yale in New Haven, Connecticut. Our objective for this educational session is to outline strategies for you to be active in participating in the treatment decisions for the management of your metastatic bladder cancer. So this is a devastating diagnosis, and it can be overwhelming for not only the patients, but as well as the family. And what I think is important is education and questions. Where do we begin? What do you ask your physician? And we need to understand all the different treatment options, what to expect in terms of tumor shrinkage as well as side effects, and what to look out for. And this is the first step in being an active participant and helping to make decisions about your care. You are an important member of the care team. The more you learn, the better decisions that you can make, and also the better you can interact with your physician. Be sure to alert all of your healthcare providers about your treatment and report any changes to each different provider involved in your care. Keep a notebook and record questions and events that you may want to discuss with your care team so you don't forget to ask. I often have patients come in and say, well, I know I'm going to ask something later on. Well, make a notebook and have a friend help you with that or a family member help you with that as well. There's a lot going on. One analogy is that I use with some of my patients that I can understand and read things about architecture, but if I had to build a bridge, I may know what the facts are, but I may not be able to actually build that bridge because I don't have the experience in doing so. It's the same thing with you, the patient. You're smart, you're intelligent, you read, but you don't have the years of experience in taking care of patients in the situation. And that's what we're here for. We're here to educate you and to help you at the same time. You need to share side effects and your experience at each visit to enable the clinical team to know changes and then adjust your treatment that may occur over time. So this is not something that occurs, or how we decide how to treat a patient is not something that's based upon one factor. It's based upon their lifestyle. Does a patient want to commit to long periods of treatment? Do they want to subject themselves to toxicity? What's the evidence behind the individual treatments that a patient may go forth with, and what are the national guidelines that are supported by that evidence? Additionally, what's your physician's experience in treating these patients? And what are the preferences that your physician may have? So again, all of these things go into play and lead to a final treatment decision, which in some respects can be adjusted based upon the patient's needs during treatment. Let's review some of the terminology that's commonly encountered in your visit with the physician. So systemic chemotherapy, these are chemotherapy drugs that may be used alone or in combination, and these are effective in your cancer. One type of chemotherapy are for those patients who are not eligible to receive cisplatin. This is because there may be certain conditions such as kidney impairment, heart failure, neuropathy, which manifests itself as numbness of the fingers or toes, that can be seen with chronic diabetes, hearing loss. So these are conditions where it may not be appropriate for your physician to administer cisplatin, which is one of the more active drugs in this disease. If you're not eligible to receive platinum, there are other options available for treatment. Maintenance therapy is a treatment that's given in addition to your first treatment. So there's a drug called avelumab, which is an immune therapy agent that is administered after patients receive chemotherapy. And this is done to consolidate or to sustain the positive effects of chemotherapy and suppress the tumor regrowth and potentially shrink some of the tumors as well. What's an immune checkpoint? Well, these are drugs that are approved for patients who are ineligible to receive platinum, and they work by binding to certain proteins called PD-1 and PDL-1, and they restore the anti-cancer activity and they reinvigorate or suppress immune cells. These proteins are associated with advanced and aggressive tumors. So I often equate immune checkpoint therapy to the old TV shows called Star Trek, where you had the bad guys who were the Klingons and the good guys who were the Federation. The Klingons had something called the cloaking device. Cancer cells have a cloaking device as well, which prevent the immune system from seeing these particular cancer cells and attacking them. The PD-1, PDL-1 system is a way that we can shut down immune cells, and the cancer cells exploit that. So by uncloaking the cancer cells, we allow the normal immune cells to surveil the cancer cells and kill them, almost like taking down the cloaking device where the Federation can kill the Klingons. So what are the different lines of chemotherapy that we may see? Well, we can break first-line therapy up into two different groups of patients. We've sort of talked a little about them already. Those who are eligible to receive cisplatin, they can receive one of two regimens up front, either gemcitabine cisplatin or another combination called dose-dense MVAC, which is comprised of 4 different drugs. Cisplatin, gemcitabine are 2 separate drugs. If the patient responds or has tumor shrinkage, this could be followed up by avelumab maintenance, and this has been shown to improve survival. For those patients who are not eligible to receive cisplatin, for those patients who don't make PDL-1, you can give gemcitabine carboplatin followed by avelumab maintenance therapy if they respond. If they are PDL-1 positive, you can give pembrolizumab or atezolizumab, 2 checkpoint inhibitors. If patients have received only chemotherapy as frontline treatment and they don't respond to their chemotherapy, as second line, you can give immune checkpoint inhibitors, either pembrolizumab, nivolumab, atezolizumab, avelumab. If they have a mutation in something called FGFR3, then they can receive a drug called erdafitinib, which specifically attacks those particular cancer cells that have that mutation. If you don't give erdafitinib, there's another drug that's FDA approved called enfortumab vedotin. This is a drug that's a smart bomb. It recognizes a certain protein on the cells of bladder cancer. In fact, this protein is expressed in practically every bladder cancer specimen. This delivers a chemotherapeutic drug directly to the cancer cell. This is a drug that interferes with the scaffolding of the cells, and if that's interfered with, the cancer cells die. So what is the NCCN and what do they do? The NCCN is the National Comprehensive Cancer Network, which is widely recognized as a standard for clinical policy in cancer care by physicians and insurance companies. The NCCN guidelines provide recommendations to physicians for diagnosis, evaluation, treatment, and follow-up of patients with bladder cancer. The NCCN recommendations are updated frequently as new evidence, treatments, and guidance for positioning of these treatments becomes available. So what's some of the data that you may hear your doctor discuss with you? One thing is called overall survival. This is how long you're going to live, or the length of time from the patient starting treatment to measuring the time that they're alive. It tells us whether the patient survival is improved or not with a given treatment. Progression-free survival is the time that a patient lives without their disease getting worse. It's a different way of telling whether a drug works, and often this reads out before overall survival. Duration of response is how long that tumor shrinkage lasts, and complete response, which is what we all would like to achieve with our patients, is complete disappearance of cancer in response to the treatment. It doesn't mean that the cancer has been cured because it can come back. It's also called complete remission. Partial response is a partial decrease in tumor size, and it's not complete, of course, but it is a partial shrinkage by something called RECIST, which is a way that we measure the cancer cells. It's or the cancer treatment. It's usually 30%. And stable disease means that your cancer is not getting worse, but it's not growing. It's not shrinking. So, what is maintenance therapy? So, platinum chemotherapy is generally used as first-line treatment. About 40 to 50% of patients will achieve will achieve objective responses or tumor shrinkage, and disease control, which includes stable disease, occurs in 75 to 80% of patients. Unfortunately, these responses aren't durable, as most patients will progress within 9 months. The median survival with cisplatin-based chemotherapy alone is about 14 to 15 months. If we administer carboplatin-based therapy, it's about 9 to 10 months. So how can we improve that initial response that we see with our patients? Well, that's where maintenance therapy comes into play. So we can reinforce and sustain the clinical state that was achieved by the initial chemotherapy response. With the maintenance therapy, you can reduce tumor burden further. You can suppress what's there from growing back. You potentially can extend relief of symptoms such as pain or weight loss, and you can potentially improve overall survival. You can potentially give the same agent or another regimen, or switch it to a different agent, or different class of agents, such as immune therapy. So avelumab, which is immune checkpoint inhibitor, is approved by the FDA as maintenance therapy for metastatic urothelial carcinoma. If there's been no disease progression on systemic chemotherapy after 4 to 6 cycles of treatment, the NCCN recommends that patients receive avelumab, otherwise known as Bavenco, as maintenance therapy. Avelumab maintenance therapy will increase overall survival in all patients when compared to patients who receive best supportive care. This includes antibiotics, nutritional support, hydration, and pain management, as well as palliative local radiation therapy for isolated lesions, but not systemic treatment. Increased overall survival was seen in all patients, including those who are PD-L1 positive, in other words, with the target for immune therapy being present. Overall survival benefit was seen in patients who had both cisplatin as well as carboplatin chemotherapy. So it doesn't matter what chemotherapy you received up front, as long as you received a benefit from the initial treatment. Now, when selecting a maintenance therapy, there is a commitment, and one, of course, worries about side effects. These side effects with immune therapy are different than what you see with chemotherapy. They're generally those that you see with inflammation. Some are mild and some are more disruptive. You can have low levels of diarrhea, but it can get quite intense. And in that situation, as in any situation, even with the smallest amount of diarrhea, you should need to contact your physician. You have to have an open line of communication with your care team so they know when you have a problem and how to manage those problems so that they don't become more serious. In fact, early treatment is crucial to continuing therapy with immune-based agents. And the reason being is the earlier we treat those particular side effects and prevent them from becoming higher grade side effects, the longer we can treat you with immune therapy in the overall scheme of things. So talk to your care team about side effects you experience throughout the treatment and after the treatment is over. You have to be highly suspicious of new symptoms. If it's something that is bothersome, report it to your physician. And if it's something that they need to help take care of, fine, you have a plan. If not, you'll have peace of mind knowing that you are not having a side effect or some other issue that's significant. Your healthcare provider should be open and accessible to you. If side effects occur, your doctor will consult with the relevant specialist. If you have a skin rash, dermatology. If you have severe diarrhea, the GI docs or gastroenterology. Also, the endocrinologists as well are important caregivers in the situation. If you really have severe side effects, your doctor may have to discontinue treatment. But again, early identification is a way that we can avoid this particular situation. So for grade 1 treatment, we continue the therapy, and there are certain parameters that are spelled out as to how much diarrhea you may have or other issues. And this is with the exception of some blood, nervous, and heart toxicities. For grade 2, you have to hold treatment. And most grade 2 toxicities will resolve on their own, and you restart when these values, particularly if the lab values, return to grade 1. You may or may not have corticosteroids administered by your physician. Grade 3 are moderately high adverse events. You have to stop treatment, and high-dose steroids are appropriate in the situation. They're then tapered. If the steroids don't show improvement within 48 to 72 hours, a drug called infliximab may be administered for some side effects. Grade 4 means that you really have to stop treatment permanently. And this is the exception of endocrine disorders, which are controlled with hormone replacement therapy and are not going to return anyway. And you're really going to be on supplementation for a lifetime basis. But I think that that's a small price to pay in return for getting your cancer and improving your cancer symptoms. So be active and participate in the decisions that are being made for your treatment. Learn about your disease and the drugs that are used that you can ask and have your physician answer the questions that you may have. Let your physician know what's important to you and your preferences for your care. Keep the lines of communication open with your care team and let them know and monitor any unusual side effects that you may experience. So thank you for joining. You can find additional information and resources at the CME Outfitters Oncology Hub. I hope I've given you some ideas and insights that you can use to help you work with your care team and provide the best care possible. Again, thank you for your attention.